Hello, everyone. Welcome to our session. Hello from South Africa, or good afternoon. We're going to be taking you through vaccination stories from around the world, specifically South Africa, Italy, and Australia. I am probably talking on behalf of my colleagues, but I think that we are all very excited to be with you today, and we hope that you will get some real value out of what we're going to be sharing with you. So I'm going to kick off talking just about a little bit about the South African journey, and then I'm going to hand over to my colleague Roberto. So our story in South Africa was one of can we help, and where it started was with our chairman Norman Fall. He read an online article, the UK Mail, at the beginning of this year, and it was really sort of describing the vaccination process and what this looked like. And they spoke about the fact that they were doing 4 injections per minute from 6 parallel lines, and the bottleneck was operating at 90 seconds per jab. So based on this, he wrote an article called Call to Arms here in South Africa. And what he was sort of focusing on in this article was around this concept of tact time. I'm sure everyone on this session knows what tact time is, but basically it's a calculation. It tells us exactly how fast we need to work in order to meet customer demand. So he did 2 calculations. He said that, within this article, he said that if an injection takes 90 seconds, we will need at least 900 resources to do what we need to do. If an injection takes 10 to 15 minutes, however, we're going to need at least 10,000 resources. And what he was trying to do here was focus on the need for us to be able to streamline, for us to make our processes more efficient in order to be able to get this done within the times that the government had sort of the targets that they'd set, and also to use as little resources as possible. And how were we going to do this? Had any thought been put into it? So, as I said, the government had sort of mandated a target for vaccinations, and they wanted to vaccinate 40 million people within 8 months. So the vaccination campaign or the rollout started in May, and they wanted to sort of ramp up to 300,000 injections per day by September. What would the impact be if we didn't achieve our target efficiency rate? So, if we achieved 60% efficiency versus 80% efficiency, well, basically that would mean that we would need approximately 1,100 additional vaccinators or nurses each day. And this is at a huge cost to the government and the country. So on the back of that article, we contacted some of our contacts that we have in national government, and we asked them, can we help? And after the discussions, we got through the initial discussions, we were tasked with solving the following 2 problems. How can we effectively and efficiently vaccinate 40 million people in 8 months? And how can we achieve this by using the minimum amount of resources and cost to government? So the first step, or the first thing that we did, was we went out to understand the process. And this was so important because, as you know, if we don't understand the current situation, then, how can we improve? So we went around and we observed 12 sites that were initially set up in the Western Cape, in Cape Town and Johannesburg, focusing purely on the process and what we could take out as best practice. So we looked at things like site layout, what did the flow look like of patients? How could we ensure social distancing, etc.? Process flow and the cycle times attached to that, any bottlenecks that were coming up in the process, variation within sites and across the sites, and any glaringly obvious waste that we could see. There were a variety of things that came out of these observations, but the key things I want to share with you today. We did a few value stream maps, and obviously we found that there were bottlenecks in the process. The process, didn't have a smooth flow. But we also found that the resources, how sites were allocating resources, was not effective in being able to deliver a smooth process. And you were going to have under and overburden and bottlenecks forming and obviously waiting. Another really interesting thing is that the national government had put together what they thought was the best practice process. And they had put this in a field guide or a guideline and communicated it out to all of the sites. The thing is that this, what I've got on the screen, is all of the steps that the vaccinator had to do, the nurse. So this is the value-adding step to the client or the customer or the patient. And the vaccinator had to administer a health questionnaire, get consent, prep the injection, prepare the vial, administer the injection, capture the batch details, and it goes on. As you can see, we were never going to get to 90 seconds or 120 seconds using this process, and it was going to cause a huge bottleneck. So we went about to design a better process that would improve flow and reduce the bottlenecks. We also found a lot of variation across and within sites. So cubicles within sites were doing things differently, taking longer, taking slower. And across sites, there were totally different cycle times, totally different processes being used. And you can see from this slide just the impact that variation has. So if we look at the slowest activity time of site 3.5 to 6 minutes, the fastest, which was site 2, 1.5 to 2.5 minutes, and the difference between their throughput rate per hour. Okay. We also, you can look at site 1, they had 2 to 3 minutes. They were doing 20 to 30 per hour, but they were using 3 resources, which is 1 more resource than the rest of the sites. So the impact is 30% of wasted resources, the waiting time for vaccinees increases, and the maximum throughput decreases by 30%. So we really had to try and minimize this variation. So being able to go and observe those sites and collect that data really gave us a wealth of knowledge that we were then able to use to help the sites effectively plan and set up, so that they didn't have excess resources, so they had a good best practice process to start off with, so we didn't have long sort of queues as soon as they opened, and they knew how many vaccination boosts they needed. So we were able to tell them exactly how many resources they needed at each step of the process, purely just using this data that we had collected. We were able to tell them how many vaccination boosts, and we'll see the impact of that now. We were even able to tell them how many chairs they needed to have available at observation. We were able to give them a realistic target throughput per hour, and also a best practice process to work from, so that they could start to get optimal flow and throughput. We were also able to put together for them a resourcing tool, and it showed them 2 different situations. It had an answer to their 2 different questions. How many injections you can do based on how many vaccine stations you will have open on the day, and how many resources you need based on how many vaccines you would like to do. And all they had to do was all sort of, automatically inputted. All you had to do is go fill in the 2 little information blocks, and voila, you have the answer to, what you need to do for the day, or how you need to set up your site, whatever the reason why you're asking this question. So, it still excites me. I've been doing this for many years, but it still excites me to this day how easy it is to be able to design good processes purely just using data and some of the tools and practices that we have to hand. So the impact of being able to do this before the sites were set up. So we basically challenged their initial modest throughput rates that were being used for planning. So we said that they expected the cycle time or activity time per injection to be 7.5 minutes. We, from our expectations and from the best practice process that we had put together, our expectations were no more than 2.5 minutes. So that would mean the daily output from their expectation was 50 per booth per day. Ours was 150. So you can see from that that we're saying that with the same amount of resources, you can do 3 times what was originally expected. Just by tweaking the process and just by being really clear on the amount of resources you needed next at each step, and standardizing. This obviously also not only has an effect on resources, but it improves flow and waiting times for vaccinees. It also reduced the number of vaccination stations that they were planning to have by half. And if you're asking why would we want to have half, is because no mass site would ever be able to get the amount of people coming per day that amount of vaccination stations would actually serve. So we would have sort of staff sitting around idle. So that saved around 5.5 million rand over a 6-month period, just on 3 mass sites in the Western Cape. So it's quite a big saving, quite a big impact. So once we had helped the sites to actually, set it up right and get all the resourcing and, the right amount of vaccination boosts there, we needed to ask ourselves, what do we need to get right on site? So we obviously want to deliver value for the customer. And in order to do that, we need to make sure the process steps are balanced so we get good flow. We need to make sure there's a right amount of resources at each step, again, so the flow is right and we don't have that issue of over or under burden. The vaccination boost was vital that they have constant supply of vaccinations. Now I'm going to show you what the best practice process looks like, but we actually divided that step of who actually prepares the vial or the syringe and who actually gives the vaccine. So we had to make sure that these were sort of really linked up and aligned, and they had constant supply of vaccinations. In South Africa, we didn't have a lot of supply of vaccinations at the beginning, so we didn't want any wasted vaccines per day. Operations needed to be standardized, and to help us problem solve and continuously improve, we had to have good communication, metrics, and teamwork to support us and guide us in the right direction. So these were the 6 things that we sort of tried to implement on site. So the first thing we did was we wanted to understand process flow. We wanted to balance it. We wanted to make sure we had the right resources, and we didn't want any bottlenecks or waiting in the process, well, as little as possible. So this was the process that was implemented. People coming to the site did a pre-screening. They then went to actual registration, and they then had the vaccination and went into the observation area. I'm sure most of you are familiar with this process. As I said, we split up the preparing and the drawing of the vaccine to the actual vaccine so that this could be done in parallel. So the first issue we found on the first day was that there was a queue forming before the screening. So right at the start of the process. This was mainly because there maybe wasn't enough resources there, and because the step was maybe a bit longer than the next step in the process of registration. The problem is, and you can see from the pictures on the left-hand side, that the queue was going outside and at the start of the process at screening desks, but the rest of the process was being staffed. There was no one else in the building. It was only at that beginning part. It was very, very bizarre actually to see. So we had to do something there. There was also a queue forming between registration and vaccination, and this is probably because the registration process was quicker. We also needed to take specific notice of the fact that the preparing and the drawing of the vaccine took 6 minutes. They did in batches of 6s, whereas the vaccination only took 2 to 2.5 minutes. So we really had to make sure those were aligned and we could see at all times what was needed, what supply was needed. So the bottleneck screening, as I said, we reduced some wasted activities, I think of about 30 seconds. We also added some more resources and the flow got a bit better. To really help us to minimize the risk of vaccine booths not having vaccinations available, we standardized that process, okay? And every 6 months, every 6 minutes, there was a runner taking syringes to cubicles. We set up some visual management and some Kanban systems. So you can see on the bottom picture, you'll see the empty sort of case. This is saying that that's empty and we need more. Okay. Then on the right-hand side, you'll see the sign that says, do not restock vaccines. We on lunch, we on a break. Okay, so please don't leave one here because someone else can be using it. And then on the left-hand side, there is vaccines waiting for someone to use. Okay, so it was easy to be able to see what was needed by the runners that were going out every 6 minutes. Then, in order to make sure that we didn't have any wasted doses, you can see from the graph on the right-hand side that we did very much so in the beginning. So what we did was we implemented a 2 p.m. count. So the site only stayed open till 4 p.m. So at 2 p.m., we looked at how big the queue was, and we made a decision from there as to if we sort of slowed down the pace of drawing the vaccines or if we needed more than we had already drawn. So that decision was made there, okay, to help us stop wasting the doses. And of course, to stop the variation, to make sure that we have the best quality for the customer, and to make sure everything adheres to clinical protocols, we put in place standard operating procedures, or we helped the site to put in place standard operating procedures for every bit of the practice, of the process, every step of the process. Okay. Standard timing, standard process with detailed steps and roles. So the last thing that we said we needed was sort of metrics, teamwork, communication to keep us on the right track and to show us, where the problems were forming and to help us to problem solve. So we set up daily team meetings with the pod leaders on the floor and the site manager to discuss the problems, to talk about, what we did well yesterday, what we can do better today. And this really helped us to continuously improve and achieve our targets. We also used A3s, 5 Ys, and the greatest thing in my mind out of the whole process was that we really transferred this thinking and these skills onto these teams at these sites, which is something that I don't think that they will ever change going forward in their careers. Thank you. That is all from me, and I will hand over to my colleague Roberto.
Thank you, Sam. So I will tell you our story in Italy that is quite similar to what Sam showed us, but this demonstrated that implementing lean will lead to the same conclusion, or to the same results. So we started. We started our support to our regional healthcare system in spring of this year, and this is the cover of a guideline we provided them at the end of our job, sharing with all the local branches of the regional system. We are in Veneto. Veneto is in northeast of Italy. You probably know the most important city there, that is Venice. And how we started? We started when Luca Zaia is the governor of Veneto. In one of his daily briefing at the local TV, said that the healthcare system should have been helped by their internal engineer because vaccine quantity arrived in large number, and providing vaccination to the recipient was much slower. So they discovered that they had some problems. So some of us watched the TV, and just some hours later, I wrote, you can see there my email. I wrote to the governor offering, for free, of course, our support to help them in improving their processes. And it happened. So, no, before telling that, in that moment, they had some problems because long queues at the entrance of the hubs. You can see here internal and external of one hub. And in that moment, it was worsening because the layer of the population that was invited to vaccination in that moment were elderly. So you can imagine the pressures on the politics on the region. The newspaper was very strong against them, even if the worker inside the hubs did as much as possible to provide a correct process to vaccination people. And after a couple of days, I wrote my email. I was contacted by some employees of the region. And in a couple of weeks, I was invited to see and to visit one hub, the hub of my city. And I was welcomed by 7 persons. The chief, the very high chief of the vaccination system of the local system. There were also the operating manager of the hub, some technicians, 7 people. And so they took me across the hub, showing me how the process was working. And immediately I see many different things. Days after, in the following weeks, I had the opportunity to visit the site more than one time, but also visiting some other hubs in the region. And what I seen was it is represented like here on the left picture. You can see chairs spreaded around, and so for people coming to be vaccinated was not clear enough how the process, how the flow was. On the right picture, for example, you can see the boxes where people are, um, uh, are analyzed with anamnesis, but they waited to be called from a site where they were sitting, just in the back of the picture, very far from here. And so it took quite a couple of minutes to cross all the corridor and to arrive inside the box were analyzed about their clinic story. So you can imagine how much wasted they had in providing the vaccination. They moved from here to here, and I was following an old man, and it took a couple of minutes to arrive there. So during this Gamba tour, I provided uh, many advices to people, and the people inside the operators inside the hub were very good in implementing immediately the advices I gave them. And of course, at the end of the process, I prepared prepared the guideline, and here I can show you only some of the slides I prepared and show them. Of course, overall, I was analyzing the whole process, the process of the customer, that is people, but also analyzing the process of the technicians, the health people working inside the hubs. And the target was first of all the safety first of all, but also providing some advices to improve the process and to have as much possible reduce timing for the workers, so to do not have so many people in providing the system. This is an overall view of the vaccination process, and where you can see the single step, the single phase of processes: check booking, medical history, inoculation, certification, and so. What I did, so I let you have, I will show you some of the advices I gave them. Thinking about value for customer, we started talking about the parking spaces, because the number of vaccination you can provide a day can be limited by the number of spaces you have to park your car. So this is an example. We had around 220 car space to park, and so considering the lead time of the people inside the process, you cannot have more than I can say 300 people in the same moment inside the hub. So this was an advice I gave them. A second is how to implement some specific lean tools, and this is in check booking. You can see here we used the concept of flow and pull. How to demonstrate it? The end of the queue or the head of the queue, this should be very close to the table where the check booking has been done. Why this? Because when someone moves from the table, the next people should arrive there in no more than a couple of seconds. So this permits to save time for the administration people here working. A second concept I suggest them was to have another side resources that can cover abnormal situation. So this permitted them to maintain flow on the most of people. The same concept I provided them in the place where the anamnesis were done. On the right, you can see what I explained to you before. So long travel from the sitting or waiting side to the anamnesis here. But on the opposite, you can see on the left what I proposed them. So having chair for people waiting for the next step, very close to anamnesis box. So when someone move away from the anamnesis, the second one, the next one can achieve the position very rapidly. So this was another way, another position when I try to explain them how to make flow inside the process, having pull, because an empty seat call for the next person, and of course visual management. So having this situation, if any problems arrive in the process, the manager of the system can do something immediately. A third aspect I suggested to use in inoculation was the cell shape and visual management. On the right, you can see what happened in one hub. where people moved from the sitting chair to the anamnesis box, and so people had to enter the box to uncover their shoulder, to be vaccinated, to cover again, and to go out. I was taking measure timing, and it took from 2 minutes to 3 minutes, depending on the people inside. And so when the vaccination step doesn't take more than 30-35 seconds and so for healthcare staff, it means that they was providing value added to the recipient for 30 seconds, but the lead time they had was more than 2 minutes. So I provided them an advice like you can see on the left picture. So I have a person here and one person for by the healthcare system providing the inoculation, but with three chairs. So one is covering his shoulder, the second is receiving the inoculation, the third just arrived and is uncovering his shoulder. So when someone has finished, a second arrive, and just after we have the healthcare staff that move to the second person making inoculation. So we could have a pace of 30 seconds every inoculation. Of course, all this can be achievable only if you have a very good standard training to people. And this is and was a real big problem because in many hubs in this region, they have something as 6-7 kind of person providing the vaccination. I mean nurses, doctors, retired nurses, healthcare students, doctors coming from the army. So and they turn every day. So every day you have a new person you have to train. So it's quite impossible to let them have the right standard to be implemented. So I suggested them to use a standard work, a standard video with caption, and providing this in a platform where people that are starting to make vaccination can see, can learn, and with some tests they can understand if they correctly understood what the standard is telling them. So this is the most important thing, and when it is achieved, you can maintain a good stability in the process. So standard job instruction are very important. Of course, going in a deeper way using more specific lean techniques, I used balance tool to understand how many people needed inside the system to provide as many vaccinations as possible a day. And so using this, I was able to provide them a couple of modules just to design new sites. This is one of that. So balancing here means that you could have only one booking check persons, of course, 4 people providing the anamnesis, only one person providing vaccination, and a couple of persons preparing the vaccine. So all of them close in a very, very small area because you need to have as much flow as possible on one side. Second, to have visibility in what is happening. And with this solution, you can have, depending on efficiency you have inside the program, up to 100 recipients an hour, or with 7% of efficiency, you can achieve 85 recipients per hour with only 10 operators, 7 from healthcare skills and 3 administrators. The same I did for small, let me say, general practitioner offices with only one healthcare guys plus one administrator. And in this case, I used also the standardized work combination table, like you can see here, providing them some advices in how they can manage up to 19 recipients an hour with an efficiency of 80% or 16 with 70%. These are only some example on what they can achieve using lean tools in their practice. Just to show you one more elements. This is a spreadsheet similar to what Sam showed you before. You can write here the number of vaccination people vaccinated you would do today, for example, how many hours, and immediately you can have the number of different kind of works you have inside the hub, the number of parking you need, and the number of seats you should have to permit people to have observation. So that's all from my side.
Thanks, Roberto. And now I'm assuming that this is my presentation that's up here now. That's a bit crazy when we're transitioning slides. What I'm really reassured about is that we're all doing the same lean. And, it's really, Samantha's story could have been, it was a fairly similar story to what we had in Australia when we worked with the Victorian government. But the story I want to tell you today is a different story. It's a story from Queensland rather than from Victoria, where Alistair and Robert and I worked for about 8 months. I got a call from my colleague, Dr. Tricia O'Moore, saying, "Help, I need help. Next week we have to pop up a clinic. And, so we've got 4 days to get it organised, and I'm thinking about doing this, and this. What are you thinking?" And I said, "Well, if you're serious, happy to give up a week, and I know I've got some colleagues online that can help." And we rolled up our sleeves, and it was a really joyous experience in working with a team that was really willing to try some new things. When we worked with Victoria, mainly in Melbourne, we together came up with some models that they'd tried, and of those models, we certainly had our favourites, and number 3 was pretty similar to the one that Roberto was just explaining, because we had a passion about not only avoiding wasting vaccine. We'd had so many experiences where we'd walked into vaccination clinics and seen wasting vaccinator time. And so what we wanted to make sure is that the vaccinator always had someone to vaccinate, and they always had vaccine. And this team model was a pretty similar model to what Roberto explained. And then the mobile model over here was really about never having a recipient move, that once they walked into that vaccination clinic, they didn't have to go from queue to queue to queue. They just sat down and they were served by a vaccinator. And so these were the 2 models we talked to Dr. Tricia about. And in the end, we did a little bit of a hybrid model, and I'll show you what that looked like. Basically, we had 2 queues. We had a queue of walk-ins, a queue of patients that recipients had already had appointments. These recipients will follow the walk-in flow, came up in the elevator, and once they got inside, basically there's no queues. We had some social distancing dots here that fed these pods of 10 chairs, where we had 2 vaccinators operating, and we had what we called a poddy in the middle, who was managing the flow of the of that little pod. The poddy was a vaccinator as well, and these 3 vaccinators worked in a team together. and they worked on first in, first out flow within their team. If you were a booked patient, you didn't have to register because you'd already done that on the computer system before you left home. If you're a walk-in, you registered in the queue as you stood in this dots. The way that it basically worked was each recipient sat in one of these chairs for about 2 vaccination cycles, just so we knew that we could always feed the queue. So we made those spots work for us, and we made these dots here where the recipients were standing working for us, but we didn't have any other queues building up in the clinic at all. And this is really just how it looked by picture. We had a recipient coming up into the clinic. This is a walk-in, so they're registering. They're doing their 2 cycles of waiting in the pod, being assessed and identified, and then consented, jabbed, observation in pod, and then job done. And they were all, I understand that the Spanish in the audience will know what a chupa chup is. I don't know who else would know what that is, but it takes about 15 minutes to eat. It's like a lollipop. And because we didn't have any active COVID in the city at that time, each recipient got a chupa chup, and they were distracted by eating that while they waited for their observation time. And that was a great hit. I'm not going to go through this in detail, but here's basically the design of the value stream map. And here's the design that we put forward had a vaccination time of 5 minutes. That include all the assessment and checking the details. And we had a Microsoft system that was across the state that actually hamstrung us a little bit in terms of processing time. And it was the reason why we're at 5 minutes here. But you can see the actual up here was about 3.5 minutes. And then we made these queues work for us so that we always knew that we would have a recipient ready to sit in that chair. One of the really good things about this model is that all we needed to do was go to the local hardware store, buy some chairs, buy some trolleys. We set it up the night before. We weren't forced to have, big cubicles. It was absolutely a pop-up clinic, but a pop-up clinic that could do 1,000 vaccinations a day. And you can see the team here the night before putting the clinic together right before they simulated the flow. And some days we had 3 pods working. Some days we had 5 pods working. And on a big day, we had 10 pods working. So this principle around designing for flexibility and scalability was really, really important. One of the other principles that came out of this work was harnessing the spirit of teamwork. And what you can see here is the poddy in the middle, and she's holding up 2 fingers because she's ready for 2 recipients to come over from where they're standing on the dots. She's managing the flow of her own team, and you can see that she's got some visual signals that she's using here if she needs help, if she needs vaccine, and she's ordering the recipient cards so that she makes sure she doesn't muck up that first in, first out order. And what we found was these teams created quite a bit of competition. This is one of our examples of one of our teams. They got broken up over the lunch break, and they were really distressed about that. And then you can see by the end of the day, they were really happy to be back together again. And so we really found that this team model of 3 vaccinators working together provided the advantages of increased clinical and logistic support, lots of camaraderie, working together, and as I said, even some competition. It was a really good model for putting non-nurse roles into vaccination. So we were using med students, we were using pharmacy students, and so it provided a really good mentoring and coaching model as well. Probably the most important principle that we learned from this work was around experimentation and improvement. And this is Dr. Tricia running the morning huddle. And every day they made changes, they were measuring and they made changes to try and improve the process. They were really committed to, how many vaccines they were delivering per hour, and they were, so delighted as they increased their rate day in, day out. I've got a couple of happy snaps as we get towards the end of the presentation. What we found was that managing flow on the landing pad, or where the dots were, was everybody's favourite job. People love to stand there and welcome the recipients and try and organise what was going on and try and manage that flow between the booked recipients and the walk-in recipients. So that was everybody's favourite job. The potties calling out for help by putting up their sign, and you can see got some visual practice here with one of our clinical support team members in the pink coming over to give a hand. But you can see without being constrained by big cubicles, we've got total observation right across the floor, which was fantastic for the staff, and staff that had worked in more traditional models with structured cubicles much preferred this model. And as I said before, the potty can order the cards first in, first out. And what we found is that they got to know their little cell of 10 and finally found that they were calling their recipients by name, which was really a person-centered approach. We had some vaccine water spiders sitting near where the vaccines were being drawn up, and they were doing constant rounds around the pods to make sure that the vaccinators never ran out of vaccines. And after it was all over, we packed up in a few hours. So it certainly was a pop-up, but was able to do really good volumes through this work. And what we learned from this experiment, we were able to take to another state. We popped another one up in Melbourne a couple of weeks later. We doubled the volume that they were doing in another site. And then we repeated it again after that a couple of weeks later in yet another site. So it turned out to be a really translatable model. We just needed one site to put up their hand and say, yes, we're willing to give it a go. We're willing to try something really different. But I just wanted to end with these principles. We're really grateful for the experience that we had with MARTA. This vaccination work has been such joyous, fun work for us to do. And really just finish with the 8 that we've come up with by working with them. So prioritising the value of the vaccinator and designing the flow around that. Balancing the key steps, which became really fun for the staff on the ground to work out how that would happen. Making sure that we design for flow right from the start. Designing for flexibility and scalability. Having someone to actually manage the flow. We found that a lot of clinics really didn't have that. They had clinical people to manage the clinical issues, but not really manage the flow. Harnessing the spirit of teamwork. Making sure that we built in quality. And then the most important one of all, experiment, improve, experiment, improve. So thank you very much. I'd like to call my team members back. I think we've got a few minutes. I'd be really interested to see if there's any comments or questions in there, but I think it might be a good opportunity for us to think about what we might have learnt from each other as well.
Thanks, Denise. I actually had a question for Roberto. Or actually you or Roberto. Did you guys have any challenges with the sites sort of, wanting to embrace the advice that you were giving them?
Sorry, what kind of challenge in providing advices to people, you see?
Roberto, did you have any challenges with getting people to implement what you...
Okay. No, it was very, very easy for people working inside hubs. So they were very willing to accept any kind of advice and to test immediately, because of course all the advices I gave them, they could implement immediately, saving time, reducing stress, and so on. So it was very, very, very easy. Probably the problem could be just to make escalation to the higher level of organization, because they have other target to achieve. So when I saw they moved from, in one hub, they moved from the previous site, a very large area, to another side, but they took a decision to have a very bad position with a very long corridor with small rooms. So it was probably a constraint because no other places to put, but very difficult to manage the situation. So for people working directly in the operation area, let me say, it was very easy.
I have a question for both of you. One of the things that really frustrated us was the privacy issue, and we had many centres, most centres, that had big cubicle structures that took a considerable number of days to set up at considerable cost. And we found that there wasn't much of an appetite in many centres in Australia to try something different until we did this one, and then it sort of started to catch on like wildfire. I wonder if you had similar experiences to that. I noticed that you did have cubicle structures in the presentations that I saw.
We certainly did.
Both of you, yes.
We certainly had those issues, Denise. We had a lot of pushback around suggesting that we should do it with our cubicles. But funny enough, the private sector did it like that. The public sector, they, were very much, people have to have their privacy, and, the patients coming in, wouldn't appreciate that.
In my case, I don't know exactly what happened, because my job was directly provided to a couple of situations, public, and they were very, very willing to accept. But after that, I gave my guideline to all the branches, but I didn't have the opportunity to visit what happened. So where I was working, it was okay, but I don't know in the other places.
Roberto, do you have any questions for us?
The question is how the government accepted your support, because in Italy I wrote to 3 governors, and only one of them answered me, accepting immediately our support, but other people didn't answer me at all. So I'm interested to understand how the politics or the government in your country accepted and permitted you to help them, because my opinion is our mission to help when we have this kind of skills, and I don't know why some of them doesn't accept or are not interested in that.
I'll be quick, Sam, and then I'll hand over to you. We've been really frustrated right throughout COVID, and we've, basically anyone we've helped, it's been through relationships. We ended up with a big piece of work in Melbourne, but that was really through a relationship that we had. And I agree, Roberto, if ever Lean could have been helpful, it's helpful through this work. So totally agree. It's difficult.
Roberto, in South Africa, we had the same challenges. We were lucky enough, like Denise, to know someone high up in government that was leading the campaign and that had attended some of our courses. So he already knew what lean could do. So he could, he could he had a vision of how it could help them. But we didn't have, when it came, so that the government were really on board. But when it came to getting sites to want our support and want us in there, that's where the problem came in. Because some sites said, actually, we don't want anything to do with this, and some sites said, okay, we'll try this. It wasn't mandated. So yeah, we also, I think we're all experiencing the same problems, just in different ways.
Okay.
I think one of the things for me was, the opportunity to go and work with teams and not have to say the word lean. Like it didn't come up. You just went out there and you did your stuff, and you didn't feel like you had to be always pushing this approach and always pushing this methodology, because it was just there. It just worked. It just fitted with everything that you were doing. And I think the other thing for me, it was a real joy to be able to bring my colleagues, my non-healthcare colleagues, into this work and share my healthcare work with them, and answer their questions. And they taught me so much as well. It was great to have a non-healthcare perspective.
I will wait for that dream to come true for me, Denise. It's I don't think I've ever been in a situation where we're not using the word lean and pushing it and, trying to get people to see the value. So that sounds awesome.
I also didn't use so much the word lean. It was just helping to reduce waiting for them, this kind of stuff. So it's not so important to tell lean, but it's important to show them how it works. This is my feeling. Hi, Chris.
Chris is back.
Guys. I am back.
Chris, I have a favor to ask. I want to show one last slide. Matt, can you pop my screen? I'll be really fast.
Okay, you have, I believe, 30 seconds.
Yeah, yep, 30 seconds. Are you able to put my slide deck back up, Matt? Okay. I don't know that if we've finished voting for the countries that you most want to visit. And I know that, Oriol has been, really bragging about his location. But I want to show you where I went for a run yesterday. It's 3 minutes down the road from where I live in Adelaide. And so I'm really looking forward to the time when people can come and visit. But if we're still voting and polling for the country that you would most like to visit, I would like to put another marketing advertisement out there for Australia.
Denise, that is unfair.
Okay, guys, I will have to cut you from the screen. Thank you, Denise. Thank you, Sam. Thank you, Roberto.
Thank you.
Ciao.